Good afternoon, everyone, and welcome. I am David Mineta, the Deputy Director for Demand Reduction at the Office of National Drug Control Policy, and welcome to everyone. Thank you for braving what I would consider now, I want to be a meteorologist, I want to call it fluffy rain. But this is, we're very excited about today. Thank you for joining us for this robust discussion on the Patient Protection and Affordable Care Act, ACA, and its effects on the delivery of mental health and substance use disorder services. The ACA's positive influence on one's ability to access mental health and substance use disorder services underscores the important role each of us plays in ensuring that people requiring behavioral health services get the help they need by enrolling in the ACA. I'd like to begin by thanking Administrator Pam Hyde and her excellent team at the Substance Abuse Mental Health Services Administration at SAMHSA for being strong partners in our efforts to safeguard mental health and substance use disorder services and make sure this work remains a priority for our nation. My thanks also to our distinguished speakers today. Your work supports this administration's commitment to improve access to services and treat substance use disorders across the continuum of care, from prevention and intervention to treatment and recovery. We are honored to have all of you here today. Now, I'd like to keep my remarks short so we can hear from the distinguished panelists who have come together for this discussion. But before turning things over to them, I'd like to speak briefly about the ACA and review the agenda for today's meeting. The Affordable Care Act is making health insurance more affordable for millions of people living with mental health and substance use disorders and who have often had problems getting private health insurance in the past. Now, there are special insurance protections. To help. Under the Affordable Care Act, mental health and substance use disorder services are among the 10 essential health benefits that most health insurance plans must cover. This can include behavioral health treatment, counseling, and psychotherapy. The Affordable Care Act also includes historic parity protections that require insurance plans offering coverage for mental health and substance use disorders to make these benefits comparable to medical and surgical coverage. Deductibles, co-pays, out-of-pocket maximums, and treatment limitations for substance use disorders must be no more restrictive than the same requirements or benefits offered for other medical care. Thus, full implementation of the ACA gives many more Americans in need of substance use disorder treatment an opportunity to be treated. Today, we will highlight how the ACA expands access to mental health and substance use disorder services with a presentation by SAMHSA's Senior Advisor, Tom Codair, who will explain federal efforts to improve access to behavioral health services. We will also hear personal stories from two individuals about how coverage through the ACA helped them access long-awaited treatment. And finally, we will hear from our panel of experts. They will talk about how the ACA is expanding treatment and also discuss some of the solutions they have found to challenges in treatment coverage. Now I'd like to introduce you to Tom Codair, SAMHSA's Senior Advisor. Tom is well known in the addiction and recovery community. Prior to joining SAMHSA in August 2014, Tom was the Chief of Staff to Rhode Island Senate President Teresa Paiva Weed since January of 2009. He served as the board chair for Rhode Island Communities for Addiction Recovery Efforts, and he is the former National Field Director of Faces and Voices of Recovery. Tom has an extensive background in government. He has served in the Rhode Island Senate from 1995 to 2003. He is a graduate of Rhode Island College, where he earned his bachelor's degree in political science. Tom now works on a variety of policy issues for SAMHSA and Administrator Hyde, including, but not limited to, substance abuse prevention, treatment, and recovery programs. He collaborates on these issues and helping to represent SAMHSA with other HHS offices and operating divisions, and also the White House. Tom is a passionate advocate and committed public service servant who will be a tremendous asset as we continue our important work of crafting effective public policy to reduce the impact of substance abuse and mental illness on America's communities. We are so pleased to have Tom as a partner, and I feel very fortunate to be able to call him also a friend, as many of you here in this audience and many of you across the nation right now also call Tom a friend. So at this time, please welcome Tom Codair.
Welcome, and thank you for coming today. First, let me thank Deputy Director Mineta for that very, very kind introduction. I appreciate it. I, too, consider you to be a wonderful friend, and he's helped me navigate this federal maze that sometimes we have to navigate here in Washington over the last 4.5 months. David called what we're experiencing outside as fluffy rain. I'm from Rhode Island, and that I don't think even qualifies as rain. But here in Washington, it's a Category 5 snowstorm, and I'm surprised that this building is even open today. But it's great to be here. I've really enjoyed working with David and the staff at ONDCP in planning this event today, something that's very, very important to us. And as we have been going through our work over the last 4 months, we've noticed that people in the recovery community and people who are out there suffering from substance use disorders don't necessarily get their information in the same way through the mainstream media as the rest of the population. And so we really thought that bringing everyone together here today for this event would help us get the message out, and that's why we're here today. And it's meaningful for me as a person in long-term recovery because I know how critical it is to have access to the care that you need in order to find and sustain your recovery for the long term, including primary care and recovery support services once you get into recovery. You know, it's not just enough to find recovery, but we need help sustaining our recovery as well, and that's why this event is so important. I know firsthand if it wasn't for the care that I received when I was going through my addiction, and then when I got into recovery, I wouldn't be here today. And so I'm grateful to President Obama for his appointment of me at the Substance Abuse and Mental Health Services Administration. I'm honored to be representing Administrator Hyde here today. It's great to be working with Director Botticelli and Deputy Director Mineta and others at ONDCP on these very, very important issues for our country. And we heard the President last night, President Obama, talk about mental health and criminal justice reform in his State of the Union. This administration is focused in on these issues, and it's because of the work of Director Botticelli and Administrator Hyde and all the other folks in government who are bringing this to the forefront all the time. And for you in our audience today, the recovery advocates from around the country who are here today, and those who are listening through the live stream. We really appreciate your efforts. And if you are listening on the live stream today, remember our hashtag. I was told this means hashtag ACA for recovery. Let's get the message out because it's really important, again, that our community hears about this event, hears about the Affordable Care Act, hears about enrollment, and knows what their options are when it comes to this. The good news is that thanks to the Affordable Care Act and the Mental Health Parity and Addiction Equity Act, more people than ever can get covered and get the primary and and behavioral health care services that they need. The Affordable Care Act, in conjunction with MPIA, has already provided an opportunity for new and expanded behavioral health coverage benefits to approximately 60 million Americans. That's something that this administration is extremely proud of. Those two acts working in concert, and we all knew that. Pat Taylor and Carol McDade and all the people who worked so hard on passing the Mental Health and Addiction Equity Act knew at the time that with the Affordable Care Act coming down the road, how important those two acts working in concert together would be for our country. I don't think any of us thought that 60 million more Americans would have access to care. And that's something to celebrate today. And you guys can applaud that too, by the way. The ACA has also created programs designed to help states and communities prevent illnesses and promote health. That's one of the big goals of the Affordable Care Act. Under the Affordable Care Act, most health plans must also cover certain preventive services without a co-payment, without co-insurance, or without a deductible. MAPIA has also contributed to expanding health coverage. The law requires health insurers and group health plans to provide the same level of benefits for behavioral health services as they do for medical and surgical care. But communities and behavioral health care providers still face challenges in getting those most in need enrolled in the Affordable Care Act, and in health insurance and in plans. And that's why we're here today, to hear firsthand how important it is for those in recovery to get covered, and to find out from our panel of experts, as David mentioned, how we can spread the word about what works best. You know, there's some really great people who have come to Washington today to share with us their work, you know, and you're going to hear some incredible stories. But before we get into the actual nuts and bolts and that on-the-ground work that's taken place around the country, I want to bring forward a young lady who is going to really talk to us about the importance of getting covered and what it's meant for her to find recovery and to stay in recovery. So it's my pleasure to introduce Ariel Spanville, who is a woman in long-term recovery from addiction, and will be celebrating 6 years in recovery next week, believe it or not, just next week. A day at a time, right? Just for today. But Ariel's accomplishments are numerous. For 10 years, Ariel struggled with an addiction to heroin, and she ended up trapped in the criminal justice system, like so many people who need help end up. And during this time, she was unable to maintain a job or healthy relationships. Today, she feels extremely fortunate to be a graduate from the University of Utah's Bachelor of Social Work program, and currently working on her Master's of Social Work, her MSW. In the last few years, the Affordable Care Act made it possible for Ariel to not only receive the physical health care she needed, but it has also played a critical role in allowing her to manage and maintain her long-term recovery. Currently, she's receiving outpatient therapy to ensure that she stays in recovery, and she's also using therapy as a tool to enhance her ability to better care for herself and others. She feels her personal growth is crucial to her work as a social worker. If she doesn't have recovery, after all, she doesn't have anything. So please welcome with me, without further ado, Ariel Spanville.
Good afternoon, everybody. My name is Ariel Spanville, and I am a woman in long-term recovery. I'm so grateful and honored to be here with you today. This is far and away the coolest thing that's ever happened to me. So I'll start from the beginning. I was born in Provo, Utah. I was adopted at a couple of days old and went to live with my adopted family. I have two little sisters who are both adopted, and had a great childhood, very blissful. I was the little girl you see running around in costumes, princess costumes and ballerina costumes. And there was a dark side to that, though. My father was tragically ill all through while I was growing up. I basically watched him die, and he finally ended up passing away when I was 12 years old. This is when my world fell apart. That same year, I was also diagnosed with dyslexia. So losing your father, getting a hefty diagnosis of that, is just kind of earth-shattering to a 7th grader whose friends don't really understand what's going on with her. And I became a very angry and depressed child at that point in time. Around the same time, I found the cough medicine with the codeine in it, the hydrocodone in it, and that was my best friend. And our doctor would give us like huge bottles of it too, not just like little ones. And the recommended dose is like a teaspoon, and I would drink like a mouthful and then try to stay awake because I loved the feeling of being dizzy. I loved the feeling of not being in my body, of not having to deal with all this emotional pain and trauma that I didn't know how to deal with. This escalated through my high school years. Started, doing what most kids, well, I guess not most kids, but what you do, marijuana, cigarettes, alcohol, it escalated into methamphetamines, ecstasy, heroin, cocaine. I did kind of the whole gamut, hallucinogens, whatever you had is what I wanted, and I always wanted more. I could never stop, it was never enough. In August of 2006, I discovered I was pregnant, and my cool, awesome, just out of prison boyfriend at the time and I were addicted to methamphetamines, and I was in no shape to be a parent. Somehow through all of that, I understood that that was not my calling or duty at the time. I didn't want him around. I didn't want to be a mother because I wanted to keep getting high. And so I decided to give her up for adoption. Being adopted myself, I saw the power that had for my mother and father, and I thought I could bestow that blessing on somebody else. So there's another tragedy in that, giving a little girl up for adoption. The good news is today she's like this awesome little kid. She's 8 years old, totally healthy, everything's good. I used through that entire pregnancy because I had no coping skills. I had no idea how to stay sober and like deal with life. In 2008, I had a few brushes with the law. Some people like to say that they were on the run. I like to say I was evaded. I evaded the law. Sounds much classier, right? I evaded the law, and finally I ended up in front of the judge and tried every which way to get myself out of trouble. Tried to go to outpatient therapy because I wasn't going to go to inpatient. I tried doing one-on-one therapy with a distinguished lady in Orem, Utah, and I was high through the entire thing. Could not, for the life of me, hear what was being said to me or understand that I didn't know what it meant to like get dressed and like put pants on and like go to work. Like I couldn't do that. And finally this judge had enough of me and sentenced me to 90 days in Salt Lake County Jail. And that was not okay. I was able to go on ankle monitor for a month or like 3 weeks. Once again, no coping skills. I had no idea how to live life, so I used the entire on ankle monitor. I was finally caught by the deputies that UA you every so often, and I was able to manipulate my way out of it because as a drug addict, that's a natural talent I have. And went back to jail like right before Christmas in 2008. And had this thought, and this was a very profound thought a couple of weeks into this sentence, and it was that maybe normal people don't get high in the jail parking lot. That was my thought. I was getting high in the jail parking lot before I would report to ankle monitor to go do my service work for the day, and I wrote my mother a letter and I asked her for help. And this was the first time that I honestly was like, maybe I have a problem and I need help. When I was in this whole court proceedings, I was sent to the Alcohol and Drug Abuse Clinic at the University of Utah for an assessment. And when I got out of jail, I went back there to see the director at the time for a referral to treatment. And he suggested a little treatment center called The Haven in Salt Lake City, Utah. I checked in January 27th. My sobriety date is January 26th, so like a good alcoholic and a drug addict, I used the day before I went into treatment. And went through The Haven. I was there for 60 days. I completed treatment, and then that was it, you know. Well, kind of. I didn't do sober living. That wasn't around at the time. I believe sober living is crucial to maintaining long-term recovery. But I was able to do 18 months of outpatient with the Alcohol and Drug Abuse Clinic. They have a women's group, and so I did that for a while, and then I was able to go see them for individual therapy, which was awesome. I mean, the Alcohol and Drug Abuse Clinic they've been there for me every step of the way. The psychologists over there have been there for me through thick and thin, through traumas and sobriety, through the good times, the bad times, through college, which just going to undergraduate and grad school, like anybody needs a therapist. And I'm extremely grateful for them today, as well as The Haven. I'm still deeply involved with The Haven, doing service work with them. I mentor a lot of the young women that come out of there and try to show them how to live life clean and sober. Thank you. So I also decided I wanted to go to school. Since social workers changed and saved my life, I decided I wanted to join the ranks of the LCSWs, and so I started that journey. And as Tom said, I graduated in May with my MSW, and that is the biggest goal I've ever set out to accomplish that I'm so close to, so I'm really excited for that. While in my undergraduate last year, I got to come out to DC and be an intern for SAMHSA, the mothership, so that was really exciting. I was so excited to be an intern at SAMHSA and get to learn where everything comes from, and you know, because of that, I was recruited for the brass tacks grant that USERA, the Utah Support Advocates for Recovery Awareness, they got the grant. They hired me to be their project manager, and that's what I get to do. I get to talk about healthcare and recovery all day, and it's so much fun, and I love it. It's the best job I've ever had. And so I get to travel around to the treatment centers and sober residences and teach them about, well, the Affordable Health Care Act, and we're a non-Medicaid expanded state in Utah, so kind of what the field is out there and what the options are, and explain to them that this is awesome. I was so lucky that I was able to qualify for the tax subsidies last year in 2013, and I made enough money that I was able to do that because I hadn't been to the doctor pretty much the entire time I've been sober. No checkups, no anything. If I got sick, it was stay away from me. If I had an emergency, I had to go to the emergency room, and starving student, emergency room, doesn't add up very well, doesn't mix. And so finally I got health care insurance, and I was able to go to the doctor, and they found a lump in my breast. I'm like, are you kidding me? Like, my whole life flashed before my eyes that I was gonna have to drop out of grad school. I was gonna lose my hair, which probably wouldn't have been a bad thing because I have a lot of hair, and everything was gonna change. Fortunately, it was just a cyst, so nothing happened. But thanks to the ACA, I got to go have that looked at and taken care of and know that everything was gonna be okay. So that's huge. If it wasn't for the ACA, I wouldn't be able to go back to my therapist office and be able to be in the in the thick of it with him. Man, he can be really mean sometimes, but I love him in a client kind of way, and and he's been with me through so much, and you know, the mental health and the health stuff is so important and critical to long-term recovery. I don't know where I would be if I didn't have, I didn't have anything to fall back on, and it was kind of like white-knuckling it, healthcare-wise, and today I have healthcare insurance. It's kind of like a badge of honor. Like, I feel really important that I have healthcare insurance, like a real person. So anyways, I thank you for all the work that you guys have done on this and supporting it, and, for my brothers and sisters in recovery that are out there, like, thank you.
Thank you, Ariel, for sharing that very powerful story. We don't need much more evidence than Ariel's life and her experiences that she just shared at this podium to know why it's so important to have the ACA and to be enrolled in healthcare. Now we're going to move on to the panel of experts. So I'm going to ask, while I'm introducing him, to have Chris bring our panelists forward. Chris Carroll, my colleague at SAMHSA, will be the moderator for this particular part of the program. Chris is SAMHSA's Director of Healthcare Financing and Systems Integration. Chris Carroll is a health economist with many years of experience at SAMHSA, beginning in our Center for Mental Health Services before moving over to our Office of Policy, Planning, and Innovation. So the panel of experts have assembled, and I'm going to turn it over to you, Chris.
Thank you, Tom. Welcome, everybody. It's certainly a pleasure to be here moderating this distinguished panel. While at SAMHSA, I've had the opportunity and privilege to have a front row seat for much of the activity around the ACA that's been going on, and to witness how the ACA and the federal parity protections are changing lives for individuals seeking and sustaining recovery. Many of you in this room drive and support this ideal that recovery is possible. And now, through the ACA, millions of Americans have this ideal within their reach. So it's definitely an exciting time now, a hopeful time to be working in the field. Lots of successes and opportunities are abound. And so I'm pleased to be joined today by our panel of experts who have come here from across the country to talk about the ACA and recovery. I'm going to call you out. Just raise your hand because I don't know if everybody can see the name tags. The panelists are Becky Vaughn, who is the Vice President for Addictions at the National Council for Community Behavioral Health. Pamela Rodriguez, President of TASC, which is the Treatment Alternatives for Safe Communities. Deborah Taylor from Phoenix House, Mid-Atlantic. Donna Dimitrovic, Director of Consumer Affairs for Optum Health. And my colleague, Paolo Del Vecchio, who is the Director of SAMHSA's Center for Mental Health Services. So we're so fortunate to have this panel of experts with the depth and breadth of knowledge they have available to us today. In a few minutes, we're going to give our panelists a chance to address some questions that we've prepared in advance, and we'll also be passing around some note cards, I believe, if you have any. They're coming from the back. If you have any questions that you'd like to ask after we do our set questions. But first, I'd like to give each panelist an opportunity to share some brief thoughts about how our nation's health reform efforts have supported and impacted the lives of people in recovery. So let's start with Becky Vaughn.
Okay.
Go ahead.
Hi, I'm Becky Vaughn. I've been working in the field for over 30 years, starting in Georgia, working with the providers there, and then most recently with the State Associations of Addiction Services. We just finished a successful merger with the National Council for Behavioral Health, and I'm now working there. My focus has been on providers, and it continues to be on providers who are out there doing the work, working with people, and providing those services. And the ACA has meant everything for them. We're moving from a system of where the majority of the funding came from the federal block grant and state funds to a system where insurance companies are now picking up their fair share. Medicaid is now expanded to cover people that it didn't cover before, and all in parity, which has been mentioned earlier, which makes a huge difference for this field, but also with an essential benefit that says these services are essential. And to me, those are the really important parts of all of this.
Pamela, would you like to?
Hi, I'm Pam Rodriguez, President of TASC in Illinois. The reason I think that I've been asked to come here and be a part of this panel today is because of the work that we've been doing in the justice system with across the country and also in the state of Illinois. A couple of, when we saw ACA, the hope and the possibility of ACA enter our reality, the opportunities it represented for justice-involved people were, in our minds, enormous. The population that we serve is largely male, previously uncovered as far as Medicaid and other kinds of health insurance are concerned, disproportionately minority males. And so about 80% test positive for substance use when they come into the justice system. And depending on your definitions, 25% or so have a serious mental illness as well. And so the opportunity for access to treatment for this population was huge. And so ACA for us looked like criminal justice reform. And Tom, I think, linked the two a minute ago when he quoted President Obama's speech last night. And so we've been working with our national partners, ONDCP, SAMHSA, BJA, NIC, Legal Action Center, and others to bring this notion to states across the country, especially expansion states at this point in time, so that they can think about what it means to have broad-scale access to treatment for justice populations. In the past, we have basically rationed treatment for these folks, and a lucky few had access if you were involved in the justice system, to now flipping the script entirely and having broad-scale coverage and access. And it's been really pretty revolutionary when the justice system grasps that notion. In Illinois specifically, we've been doing some enrollment activities. One of the innovations, I guess you could say, that we've been able to work on has been broad-scale enrollment at the point of intake in Cook County Jail. And so this is a population, the justice-involved substance-using offender, is a population that has very little access to care and is difficult to do outreach with. And so we knew that the intersection of this population was very strong at jail enrollment. So we've been able to do enrollments at application assistance at the jail, and now 9,000 people who started their applications in jail have health insurance. This is all done in partnership with leaders from the justice system and healthcare. We can't do this alone, and so these efforts are collaborative and have proven really successful in changing the minds of our partners. The justice system reflects pent-up demand for care, and the Affordable Care Act represents a huge opportunity to access care on a broad scale for this population.
Debbie?
Okay, thank you. Whoa, that's loud. I guess I'm here because I represent a provider network of, Phoenix House is probably, I guess, the largest not-for-profit substance abuse treatment provider, behavioral health provider in the country. I personally came in the back door. I'm a psychiatric nurse by training. I'm personally not in recovery, but have had the extraordinary opportunity in the 42 years that I've been involved in this field to work with thousands and thousands of individuals who have approached recovery, and to watch that process in so many, many, many different settings, whether it be full corrections settings, whether it be full mental health settings, whether it be substance abuse treatment, outpatient, inpatient, residential, adolescent, mothers with children, pregnant mothers and children. I think that I have had the extraordinary opportunity to work in every possible modality that exists for substance abuse treatment, because I was so enthralled with what it was like to see the Ariels of the world move forward and have the privilege to be facilitating that or providing an environment where people can get that. I think from the Affordable Care Act, I have a perspective that I guess maybe is jaded, in that I have watched the system go from where you couldn't treat an alcoholic in the same place that you treated a drug addict. We gave people drinking privileges when they first left treatment. That's how old I am. To the point where mental health, and you couldn't be in an AA meeting if you took a psychotropic medication, to the point where you were either a criminal or you were those people or whatever. The stigma has always been there. My hope with the Affordable Care Act is that that will somehow transcend that. I am seeing many more people who were underserved in their own insurance or uninsured who are now receiving access and the actual quality of treatment. What I guard against is that we medicalize it too much. There are a lot of clinical aspects of recovery that need to be addressed that are different than a pure medical model. I say that as a nurse. I think I know the difference. And that is my caution. So hopefully we can talk about more of that. But thank you very much for allowing me the opportunity.
Donna?
Hi, everybody. My name is Donna Dimitrovic, and I am Director of Consumer Affairs for Substance Use Disorders at Optum National Office. And I work in a managed care company, so I'm today hopefully going to be able to provide to you some of the really innovative and important work that we're doing at Optum, focusing around recovery and resiliency, wellness and well-being, and looking at our members as individuals, not only for their behavioral health issues, but also their physical health issues. And so there's been such an expansion of folks being able to get insurance through the ACA, and we are trying, as an organization, to really bring recovery supports as part of the work that we do to engage people in their recovery. And I'm a woman in long-term recovery, and I've been working in the field probably the last 28 years, so 28 out of the 29 years I've been clean and sober. And I too have seen a lot of different changes over the years, but it really, the work that we do at Optum, I'm really excited about the focus on recovery and resiliency. Our clinical model really focuses on that. And in the department that I work in, the Consumer Affairs Department, what we do is work with members and we work with staff to make sure that we always have recovery at the forefront of what we do at Optum. Thank you.
Thank you. Paolo?
Thank you, Chris. And for me, the Affordable Care Act means hope. It means hope for the millions of Americans like Ariel, like myself, like many folks in this room and across the country. Hope that we can access the needed prevention, treatment, and recovery supports that we need and want. Hope that we can regain our lives. Hope and real opportunities for recovery, for life and dignity. And I'm going to quote the President's remarks last night at our State of the Union when he said, "I want future generations to know we are a people who see our differences as a great gift, that we are a people who value the dignity and worth of every citizen, man and woman, young and old, black and white, Latino and Asian, immigrant and Native American, gay and straight, Americans with mental illness or physical disability." For me, ACA is about hope, dignity, and recovery.
Thank you, Paolo. Let's start with the questions. They get progressively harder, so be aware of that. The Affordable Care Act has certainly created access to services for millions of individuals with behavioral health conditions. What are some of the types of services in which you have seen an increased demand or utilization? Are there services or programs you have developed to ensure that people get the necessary services they need?
I can take it.
There you go. You got one.
We have, I'm going to use Cook County as the example, several projects designed to increase access to care as a result of the Affordable Care Act. One of them is a healthcare reform ready courtroom, where they are developing policies and practices that can be generalized to every courtroom that relate to diagnosis, but really relate, and referral to treatment, but relate first to enrollment. And one of the things that has emerged out of this courtroom is an overwhelming demand for outpatient services. The criminal justice system frequently relies on residential services as a substitute for incarceration, but they've been very useful or helpful and interested in outpatient services, medication-assisted treatment, and outpatient mental health services for a very seriously involved justice population. So I think those are the three services we've seen a significant increase in demand, and I'm really happy to see that the justice system has veered from its usual path of starting everybody in residential treatment to recognizing the value and the viability of outpatient services for a lot of the people that they serve.
Locally in the Mid-Atlantic area, which is pretty much the Washington, D.C. area, we are seeing a huge increase in the 18 to 30-year-old demand for treatment, serious and acute treatment that we did not see before. Many of them are now able to afford treatment because of the being covered under their parents' insurance. The Affordable Care Act did a tremendously good thing by allowing that, because I came from adolescents. These are 26-year-old adolescents. They've been using drugs pretty much since they've been 14 years of age. They haven't really matured in the way that we would hope. So there was a tremendous need for that. And due to that age, like you were saying, the need for the outpatient continuum also was a very, very important part of that. We had to start partial hospitalization programs, IOP, and less intensive, so that we had a continuum of care following that residential episode that would keep that person attached to some sort of treatment, some level of care for up to a year. What we're lacking still is the recovery housing, because there is no method to pay for that. And that's a serious problem. We also see the same issue with the veterans. We get many veterans who come to us through the criminal justice system, not through the VA or not through TRICARE because they've been discharged. And they're suffering the same issue and have very similar needs to this youthful population. So that is where our tremendous change has occurred in our population.
I'll try to add to what's already been said, which is all very true, particularly from the provider standpoint. We already have a treatment gap. We already have more demand than we have services as it is. So in some ways, we're trying to deal with the fact that with Medicaid expansion and with more opportunities through the insurance, we are going to have even more demand. We're looking, many of our providers are expanding outpatient treatment to do some of that. We're still dealing with issues around residential or subacute non-hospital services. We don't have enough of that. There are still issues in terms of Medicaid, in terms of that need to be addressed with the IMD exclusion. But these are all the things that are beginning to be talked about now as a result of all of this healthcare reform and legislation. So many of our providers are looking to how they can expand services for the populations that you've just heard about, as well as how to get people enrolled when they may not even realize that they qualify for either Medicaid or some type of insurance. So these are things that are being put into place right at intake. Many of our providers have done a lot of changes to their intake through eligibility and enrollment processes so that they can help determine what folks need or what folks are eligible for so that they can get the services that they need.
And if I could just add real quick, Chris, one of the most dramatic things that I've certainly witnessed, and I think we've all witnessed over the last 10 to 15 years, is the development of the peer workforce in behavioral health and the development of peer specialists and recovery coaches, because as many folks know in this room and around the country, unless you've been in another person's shoes, being able to relate and connect with another person through mutual support, through peer support, being able to use those relationships to help educate and support one another through times good and bad, that makes all the difference in the world.
I just want to ditto what Paulo just said. The work that I've been doing at Optum in the Consumer Affairs Department, we've really been focused around getting peer recovery coaches as part of our network of providers, so that when there is a gap in services for individuals to get into treatment, maybe in their community, they could get connected with a coach to help support them until they actually get into the treatment process. We realize that's very important. We also have built a lot of tools that are available to our members, addiction recovery toolkits that provide websites and resources to our members that help support their recovery process. We also have done some videos on newly diagnosed, or what if I'm a family member of someone that has an addiction issue, what can I do? So we've been doing a lot of different work around supporting our members and providing them with information, making sure that recovery supports are an integral part of that process. We know, prevention, treatment, intervention is all important, but we also realize that recovery support services is important to individuals when they get back into their community.
Thank you. Second question. Behavioral health providers, either through insurance benefits expansion, Medicaid expansion, or the Mental Health Parity and Addictions Equity Act, find themselves positioned differently now. What have been some of the challenges providers and systems have faced in being prepared, utilizing newly available and somewhat non-traditional funding streams, and coordinating care for the formerly uninsured? What are the successful approaches that could be shared and replicated?
I would like to start with that, if that's okay. That is a huge, huge, huge issue for providers. I had the opportunity to spend a couple of years in Texas for Phoenix House and looking at how they did it. And Texas was was very similar to New York in that it was a single provider that was also their regulator. And while I was there, they went to managed care. And to watch what happened as a result of that when people were not positioned to be able to getting authorizations and getting utilization review and having people that could speak that language, and the amount of backroom staffing and expertise that is required to now work in a Medicaid or a managed care environment as opposed to a block grant funding or a per diem or even a contract basis, which many of our organizations, like in New York and California, have operated in for years. You know, I'm talking about 50 years. So you're talking about changing extraordinary infrastructures with timelines that are very, very difficult. And, you know, I don't know what's going to work except to try and educate and provide systems for people to be able to make that transition and to buy them some time.
I'd just like to add to that. We also recognize that our providers are very much behind the 8 ball and trying to catch up in the business skills that they need to operate in this kind of new environment. We've asked people to kind of move from being a social service agency that was funded to being an actual business in the business of healthcare services, and that's a pretty big leap. SAMHSA, to its credit, has made a huge investment in providers in this arena. They have funded a program called BH Business that we are particularly proud to run that program, where we actually take providers, put them in learning communities to teach them how to do things like contract management, strategic business planning, how to market your services. Most of our folks have dealt with who showed up at their door. It doesn't even occur to them that they need to now understand how to market who they are and what they do. Even this eligibility and enrollment, we're asking people to change their intake process and understand how to do that. You know, if you and I walk into a doctor's office and our insurance isn't quite right, the doctor's office says, you know, go. When you get it figured out, come back. We can't do that to the people we serve. We have to help them solve those problems. And so we've now got to be insurance experts as well as experts in the services that we provide. So this program has been a huge help. It continues to be a huge help to providers because those are the new skills that they now need in order to operate in this environment. And that, to me, is probably one of the most important things we can be doing to make sure we don't lose capacity and that we can actually gain capacity, because our providers will be able to not just survive this transition, but actually thrive in this environment with all these new funding opportunities.
One of the things that we have available through Optum is what we call the Sustainability Institute, and we were able to offer that last year at the Faces and Voices Executive Directors Leadership Academy. And what it is a 1 day of training where we teach community-based organizations about partnering with managed care, what that means, what you have to do in order to get a contract with managed care, and whether that's even something that you would be interested in doing. So while I can't comment on some of the other things we talked about, I certainly can let you know about that. And it really is very helpful, speaking from my own experience when I worked in a nonprofit and we went from a fee-for-service or block grant kind of funding into a fee-for-service Medicaid reimbursable. It was a big switch, and it was a huge learning curve for us. So it's really helpful to have education available to you as an organization to understand the process.
If I could say something about the experience of coverage from the client's perspective in this case and their interaction with providers. A couple of things occur to me. Our clients now covered by Medicaid have choice, criminal justice clients, in ways they have not had choice before. And so they're exercising it, which means they're going to a much broader pool of providers than perhaps previously were able to treat them. Unfortunately, that broader pool is not familiar with this uninsured population. And so when my client walks in the door and the receptionist tells him or her that they can see him in 3 months, he turns around and leaves and doesn't realize as a newly covered person that means he has to schedule his appointment today and remember to show up in 3 months. And so that provider, who's not used to this population, has to change their practices in order to not lose the clients we're serving. And then the provider who is more familiar with the client population has to deal with the fact that not only does this client now have insurance, but he or she has insurance from, in Illinois, one of 18 different plans, and they have to figure out which of the 18 plans it is and which services are covered. So the world just got much more complex for both providers and for the client, who is, and one of the things that we've been doing for this population is really emphasizing health literacy so that they can become good participants in their care and their care coordination. And that, I think, I would argue, is also an important piece of this reform effort.
And I would just add that clearly one of the greater complexities and challenges that providers and all of us face is the need for integrated care approaches. It is a national shame that people with behavioral health disorders die decades earlier than the general population. And the need for us to address the primary health needs of individuals with these conditions is an imperative. And the need for coordinated care approaches to meet the holistic needs of people is something that clearly has to be addressed.
Thank you. Paolo? Are there specific outreach and engagement strategies you have used to encourage enrollment for individuals with behavioral health conditions? Are there specific populations that are hard to reach or enroll?
Yeah, one of the hardest populations to reach and enroll are the people who have mental illness and SUDs. So it makes our job, we learned from the Massachusetts situation that when they got so many people covered under insurance and less than 5% were uninsured, yet the people who showed up at our doors, 25 to 30% were coming in without any coverage. So these folks are hard to reach and hard for them to understand what their options are. One of the things, CMS has put out a really good publication, a roadmap to better care and a healthier you, from coverage to care. Because the other thing we found out is just getting them enrolled doesn't mean that they know how to take advantage of now all the benefits that they have and the services. As Pam said, it's a literacy thing. They've never had this opportunity, so they don't understand that they can go to a doctor, they can see someone to help them. And so a lot of the providers, beyond just getting them enrolled, are now trying to help them understand how to take care of themselves and how to make use of the services that they have. So we are using many things just in the very initial thing, and many of our prevention agencies, many of our recovery support agencies are doing things to help them understand what that means. And many of the programs that are doing a lot of the harm reduction work are also talking to them about, you have more than just what you've had in the past. And they are doing a tremendous outreach job in terms of bringing people in and helping them understand what resources are available to them.
One of the ways that SAMHSA has addressed issues of enrollment and eligibility are through the use of recovery community organizations to assist other individuals in recovery with enrollment, Medicaid eligibility, as well as accessing needed services. So through our brass tacks work, Ariel mentioned that in her remarks, over the last 3 years, we've funded 35 of these projects in 24 states. Let me just cite one example of some of the work, and I know Mary Ann is here from Massachusetts, and we were able to fund her organization, the Massachusetts Organization for Addiction Recovery, along with the Transformation Center, to form a partnership to disseminate state-based information on health reform through peer recovery networks. And this was specifically to assist in eligibility, enrollment assistance, also assisted in looking at ways that peers and families can be involved in policy development at the state level as well, in terms of helping to shape health reform processes as well. This is just one example of the many projects we have funded. I'll make a plug right now that we have funding availability right now. If recovery organizations, peer organizations are interested in learning more about how they can get resources, this is $40,000 per project. You can go to our website, samhsa.gov, samhsa.gov, /brass tacks, which is BRSS-TACS.
So I mentioned earlier that we've been doing enrollment at intake at the jail. Because of where we're positioned, we do it, at in the courtrooms for people who are coming to court. We do it at release from jail. And it isn't just us. We've been training other people to do the same thing. So across the state and across the country, we've been working with foundations and national partners to access what we think may be among the hardest to reach of the folks with substance use disorders and mental health disorders, and that is those folks involved in the justice system. And because they cycle in and out of coverage and eligibility, and so that becomes a particular issue for the population. And so every point of contact, we view every point of contact with a justice involved individual as being a time to do application assistance.
Okay, thank you. As previously stated by Tom and others, more than 60 million Americans will gain access and have federal parity protections in obtaining the mental and substance use disorder services they need. They still need to sign up, and they still need to understand parity. So this is a two-part question. I told you they were going to get harder. What have been your experiences regarding educating individuals and providers about the parity law, and what can peer and recovery community organizations do to help people understand, enroll, and access services afforded by the ACA?
I'll take a shot at that. I think we have not everybody knows that the Parity Act actually is in force. And I'll say that about the consumer, the clients we serve, their families, and the insurance companies that are paying for their service. So in many cases where we have to get authorization or reauthorization, we have to consistently remind the insurance company that there is a Parity Act and refer it to them on a very, very, very consistent basis, and ask to speak to supervisors and work your way up the totem pole till they actually go, oh, okay, well. And then, of course, the criteria then changes a little bit on, well, it's not really the same thing. So it's a constant struggle and it's a constant battle, but it's constantly having your staff informed of what the law is and providing that at every opportunity. In terms of the ACA, I think that's pretty easy. That's a lot easier. I mean, if they have it and they're enrolled, and they understand that if they lose their coverage because they've lost their job, they can then go on the exchanges and actually become re-enrolled, and we provide that opportunity to them constantly. As well as providing them information when they call, because we have a huge crisis line that operates throughout the country. And there's thousands of calls that come in that, and many of those individuals have no insurance or have lost their insurance. So it's a constant education process of figuring out what navigator can they go to help them get through that process to be able to figure out where their benefits may be, but it's a constant work in progress, I think.
No, I agree, and many of our providers continue to have a lot of issues with parity. Tom mentioned some of our parity heroes that are in the room right now, and many of them continue to do work because now everything turns to enforcement and how it's going to be enforced. And so often, many of the people we serve, it's easier for them just to turn around and walk away when the insurance company says no. Many of them are looking for any reason to turn around and walk away, and we just hand them to them when we get involved with the insurance. So once again, it often falls back on the providers, like Debbie was saying, to suddenly be the insurance experts and be the ones that are battling with them, knowing, no, you can't deny this person these benefits. But that's going to continue to be something that we all have to be focused on, because it sometimes is easier just to give up and walk away, and that is not going to get us to where we need to be. I know Carol's collecting anecdotal information when people get turned down. Those are the kinds of things we need. Legal Action Center is doing some work in this area, but if we don't report this stuff, if we don't collect this stuff, then we can't make the case that it's not being enforced. Or as I like to say, that we have a different view of the parity law than some of our insurance companies have. And so that's what we have to continually be vigilant about, or else we'll lose this great opportunity we have if we do not push this and if we do not help the patients we serve push this so that it will benefit everybody in the end. I mean, I have a family member who now, you know, because of the ACA, he's covered up to 26, like we talked about, and he actually pushed when the insurance company tried to put a limit on the number of sessions he could have. He pushed, and he has now got unlimited sessions. And so it is possible, but not if we aren't all vigilant and pushing on these things.
And I couldn't agree more, Becky, and the need for, again, Chris, as you noted, peer and recovery organizations to lead the way with that kind of education. Here's another example of a group, the Healing Place of Huntington, West Virginia. Through our support, they implemented a hands-on learning approach called Hands-on Enrollment and Learning Peers to Peers, or Help to Peers. Helped provide education on eligibility, Medicaid expansion, face-to-face Medicaid enrollment assistance to other providers, such as homeless shelters, voc rehab programs, particularly in rural areas. Just in the short time this program was supported, it helped enroll almost 200 people in Medicaid and other benefits, sharing information with over 1,300 individuals in addictions recovery, and helping form a health reform-focused partnership with 22 other organizations. This is making a difference.
So one of the things that we've been able to negotiate is for certain plans, individuals can be admitted directly without prior authorization and into substance use disorder treatment. That's a huge deal because, as Becky said, our folks will take any excuse to avoid or to walk away. And they're used to being rejected, and they're used to being turned away, so they expect it. And so just by negotiating with several of the plans, and we're hoping that it becomes like a best practice across all the plans in Illinois, this need to not have prior authorization, people can walk directly from jail into a substance use treatment provider. We're hoping that we begin, we inch our way closer because coverage does not equal access, right? And oftentimes access does not equal care. We have to really work the entire continuum of decisions that affect our clients' lives. And just recognize, like for yourselves, with your own health insurance coverage, oftentimes we get told no with our first approach to insurance, and we fight for ourselves, and now we're fighting for access for our clients as well.
Thank you. We are running a little tight on time. I would like to get to the pile of questions that you've submitted to, but one last question here. Are treatment providers finding it easier under ACA to get reimbursed for medication-assisted treatment for patients presenting with opioid use disorders?
Great question.
Go
ahead.
Okay, sorry, go ahead.
Now, I can tell you that is a not, I wouldn't say it's easier. It is a challenge. The medications are listed on the formularies as covered, but oftentimes there are things like fail first provisions, so people don't have immediate access to medications, and the advocacy we mentioned with regard to parity applies, I think, in this as it relates to other medications for the treatment of opiate addiction, at least in Illinois.
I could say locally we've had very good luck with it. There's you have to be clever, and it has to be presented in an appropriate way, and it has to be, presented in a medical manner by the right provider. And that being done based on the actual facts of the situation, we have not had any problem with it. But there is some controversy on when someone should be receiving it, especially criminal justice populations. That is where we've had the most difficulty making that case.
Unfortunately, it's still a very state-by-state situation. Many of our Medicaid state departments are still trying to figure out what an SUD benefit looks like because they haven't covered that before. Many of our insurance companies are trying to figure out what this looks like. So it is very sporadic. I would say some of our providers, things are better. They've been at the table. They've worked with them on how some of these processes are going to work. But in many cases, it depends on the insurance company and it depends on the Medicaid state office as to whether it's easier or in actuality, we've got some reports of it's actually more difficult now. So it's very much a mixed bag, but as I continue to say, it's going to be okay in the end, and if it's not okay, then we're just not to the end yet. So hang on, and we will keep working on it.
And I would just add one resource that we recently developed on this issue with the ASAM, ONDCP, NIDA, and our Office of the Assistant Secretary for Health, a guide called Advancing Access to Addiction Medications, Implications for Opioid Addiction Treatment. Should be able to find that on our website as well.
I have a question for you.
Who, me?
I do.
Oh, okay.
So it's the end of the table.
Go ahead.
Is a hard place to be. For Donna, can you explain Optum's success with funding recovery support services such as recovery coaching?
Well, originally, prior to my coming on board, we did a lot of mental health peer coaches, and we did internal studies regarding the success of that. And so as we started to move into addiction recovery, we were able to show the success of helping people and supporting their recovery process, and that's how we actually got that into the market.
Another question from the audience. Do you think the ACA will give access to residential treatment for longer than 28 days or even for 28 days?
So one of who do we ask that to? Somebody thinks we have a crystal ball up here or something.
Exactly.
Yes, I've been accused of being a Pollyanna before. I do think so. I think I want us to move toward the idea that there is no such thing as a 28-day program or a 6-week program or anything like that. No other health care is based on graduating from some kind of program like that. So I hope we will get to the place where we have the full continuum and nobody will be staying in that subacute, non-hospital setting for very long, and certainly not any longer than they need to, so that they can then step down to the next area and then the next area. And we can get out of this vicious rumor that we put people in residential treatment and throw the key away. Because that is just not the case at all. On the other hand, 3 to 5 days is not enough. And we do still have some people claiming that that should be enough. So my hope is that as we begin to develop all this and insurance companies and Medicaid decision makers begin to understand what a continuum of care looks like, that they will see the benefits of providing that full continuum of care so that we get the best possible outcomes and not putting people in an outpatient program because their diagnosis called for that level of residential treatment and we don't have it, and then we wonder why we get bad outcomes. Mm-hmm. So I am very optimistic that as we can explain the full continuum of care and show all the science that backs this up, that we will have people understand that if they want the best outcomes, and in many cases the best outcomes is reducing the health care costs of these people, then that will be accomplished by providing all of these services at the appropriate level that people need. So I am very hopeful, and will continue to do that message.
This appears to be a 3-part question, so this may be our last question, I think. How have the treatment programs embarked on the integration of services with primary care? How has the ACA facilitated this integration? How are services for prenatal exposure being addressed?
Whoa.
I think that is our last question.
Can I say, I'll say a little bit about that. I can't answer all 3 parts. I guess, again, I'm optimistic as well. It's almost impossible not to integrate care because our folks present with all of the issues and problems that you might expect. They don't have 4 years or 40 years of substance use disorders or mental illnesses untreated frequently and not have a lot of health care primary care needs as well. And so our folks tend to get that care integrated through FQHCs and partnerships between substance use treatment organizations and FQHCs is one of the main ways that I see it happening. But there are also some really nice innovations with substance use treatment providers bringing in primary care into their own organizations and partnering that way as well. I do like to see the partnership between the two and not defer or direct primary care physicians to also become experts in substance use treatment disorders. I don't think that that's a realistic notion. We're talking about integrated care, not all care being provided by a single entity.
And I would just add to that, clearly around integrated care at SAMHSA are investments in the primary and behavioral health care integration program. We've served over almost 40,000 individuals across the country, bringing primary care into behavioral health care treatment programs. This includes collaboration with the National Council and others for our Center for Integrated Health Solutions. So again, I encourage people to Google that, the Center for Integrated Health Solutions. Certainly the ACA has brought health home models and integrated coordinated care models to address including the needs of people with behavioral health disorders. One thing I'm really hopeful for is the development of something that we're working on right now, and that's certified clinical behavioral health clinics. And this will be a new demonstration program. We're working in conjunction with the Centers for Medicare and Medicaid Services and others to establish new criteria for community behavioral health clinics, which would then be eligible for enhanced federal Medicaid dollars. This would include integrated care approaches, and we really see this as raising the bar in terms of the quality and community behavioral health care across the country, as well as obviously the needed financing, and really bringing, again, more hope to more people around the country.
Chris, I think the answer is yes. The ACA has helped with that, and I think integration is very important. But it's pushed us away from this idea that we treat the head over here and we treat the rest of the body over here. And that is what's helping people understand how important it is to integrate all forms, primary care, behavioral health, and every other chronic disease there is. On the website that Paula just mentioned, on our website, we have a document that has a variety of models where SUD providers have brought primary care onto their campus, as well as the partnerships, as Pam mentioned, that many of our folks have with FQHCs and other primary care entities. But we need a whole lot more, and we need more from the primary care folks understanding that we know what we're doing, and we are the best people to partner with, and we, instead of just this idea that they can suddenly hire a couple of counselors and say they have an SUD program. So we need both sides really pushing on this, and ultimately the best thing is for the people we serve, and that should be the ultimate goal.
Okay, well, I apologize for not getting to all your questions. There's some really good questions here, so I don't know if we could work on some way to get these answered and out to people. But thank you to everyone on the panel for your insights, and thank you to the audience for your questions. I hope what you've heard today will be helpful to you, and that you can walk away from here with some additional insight as to what our esteemed panelists have provided to you. So with that, I would like to thank you, and I'd like to turn it back over to Tom. Please thank our panelists for their participation.
Thank you to the panel. That was great, obviously, a lot of information, and it shows the complexity with which we're dealing with when we try to implement the Affordable Care Act. And I don't think that was lost on anybody when they were going through this process, and now we're seeing today, as we continue to go through it, it's going to continue to need to be worked out. We're going to need to correct things that aren't working, and we're going to have to continue to revisit other parts of it, and then we're also going to have to celebrate the successes, too, as we heard here today, that there are a lot of people who are getting care today that never would have gotten it beforehand. So thank you so much for bringing that forward for Chris, for Paulo, for Becky, Pam, and the other panelists. We really, really appreciate it. We now have the opportunity to hear another personal story about the importance of getting covered. This time, it's the perspective of a family member who has a loved one in recovery. Nora Zarabia is a single mom with a son in recovery, and thanks to the Affordable Care Act, her son Alex, who's now 22, right? 22 years old, will be able to remain covered under his mom's insurance plan for the next several years until he's 26 years old. Nora was kind enough to agree to come here today and share her story, so please give a warm welcome to Nora Zarabia.
Good afternoon. My name is Nora Zarabia, and I'm here to share with you my journey as a mother whose son is on the right path of recovery from drug addiction. Today, my son is looking forward to going back to school actually next week. He's looking forward to cultivating new friendships, to enriching his life with new experiences, positive ones, and to help those who are in need. I feel incredibly fortunate and grateful for today. A couple of years ago, I would have never imagined that I would be here in front of you telling my story. In my mind, addiction was as distant as Ebola. I was aware of such a terrifying disease. Back then, the devastation, how entire families were lost. I hoped for a cure to end all that suffering. Truly touched my heart. But Ebola was in another continent. It was far away. Addiction was like that, far away, somewhere else. How wrong was I? Our journey starts years before. My son, being a teenager, was acting like one. It was part of growing up, I heard. His behavior changed. He was having trouble sleeping. He couldn't get up early enough to go to school. He had a short temper, didn't talk much, and when he did, it would end up in an argument. Still was part of growing up, I heard. The first time I found out that he had been smoking pot, I felt very disappointed. But now it was in the open. Mom, I won't do it again. Sometimes people do it at one point or another. We had conversations about saying no to drugs. What happened to that? Things would appear to get better, and then there would be an incident, and then another one, and then the next. Each of them being the last time. And each time I reluctantly chose to believe that it was, in fact, the last time. The addict makes excuses for anything you question or find in their possession. It didn't matter if I was holding the evidence in my hand, there would always be an excuse for it. I felt there was something deeply wrong, though I just couldn't give it a name. I didn't know what it was. Things were not going well. Family dynamics changed. I completely stopped trusting him. And the doctors would tell me that he was perfectly fine, that he was healthy. It's a phase. Any kind of therapy was out of the question because he would not want any of that. I got to the point where I had enough with this behavior and contemplated an intervention. I painfully realized that I didn't possess the skill set to fix this issue, that this thing was something I could not deal with on my own. Whatever was afflicting him, I first needed to know what it was, and then I could find a solution. Even then, I didn't even think about addiction. I consulted a therapist who advised me to look into various programs, wilderness programs, military schools. The cost for any of these options was astronomical, thousands of dollars. The insurance would cover some of it, and the part that wasn't covered, coupled with the period of time I thought he needed, was still a lot of money. It was highly evident his well-being was deteriorating, and I decided to arrange for an intervention. It was just a matter of days before that when he got sick with mono. He spent a few weeks in bed, during which he apparently had the time to think things through. Once he was healthy enough to go back to school, things got better. We were through with that phase. Finally, I thought, although I have to say I always sensed that I should not be too optimistic. It all seemed too good to be true. College started great, good grades, a part-time job, new interests, but at some point I could sense again that something was not okay. I could hear it in his voice whenever I would call him and when he stopped calling me altogether. I felt alarmed again. Whatever it was back again. And being a young adult, it was very hard to convince him of anything. A very dear friend of my son, someone I would consider an angel and who will without a doubt become an amazing doctor one day. She talked to him into seeing someone and to consider that he had an addiction. My son arranged for me to meet him and this therapist who had immediately advised him to go into the 12-step program. He admitted he had a problem. This is how I came to learn that my son had an addiction issue. It was the first time that I felt my feelings of uneasiness and that sense of impending doom had a reason for being. It was also the first time that I felt incredibly guilty for failing to see all these signs earlier on, for not following my instincts regardless of what the expected behavior would be of a teenager. How could I have been so arrogant to think that this would not happen to my family? So what to do now? I didn't know much about addiction. As I said before, for me that was far away. I didn't think it was a disease either. I had not had experience with this, no one in my family before. Needless to say, that very day, I started my own education on addiction. The information was overwhelming, but it was there. Time was of the essence. He had been struggling to stay clean on his own, and I felt I should learn as much as possible to make good decisions as far as his treatment was concerned. My son relapsed one more time during that period. He was feeling really down in all aspects of his life. Feeling of regret, hopelessness, anger made for difficult days. Yet, knowing more about it also brought a ray of hope. We learned of the latest medical findings on how the brain is affected and hijacked, co-occurring disorders, treatment programs. Addiction treatment is not cheap. We looked at various programs and how they were structured. They were expensive. It was clear to me that treatment would have an impact, economically speaking, if insurance was not available for it. But we were relieved to find out that my insurance covered for the treatment, or parts of it, through the age of 26. He's only 20 at the time. Without this, it would have been very, very difficult for my son to get the care he needed. Working with my insurance, we found local programs and opted to enroll at the Aquila Recovery outpatient program. Their model seemed to resonate with us, and we were right. Staff is caring. They keep up with new developments in the area of addiction. They're involved with the community. my son started getting the treatment he needed, and little by little, we started seeing positive changes. On my part, and thanks to their family resilience program, I am learning how to provide the right care for my son and the rest of my family. So today, I can say that I'm feeling incredibly blessed. We have knowledge, support, and hope for a bright future. We know that addiction is a health issue. We know that there are centers like Aquila that offer treatments that work. My son's life is turning around. A couple of days ago, he was getting ready to go for a run. He let me know he got his books for school and had a smile on his face. I had not seen that smile in a long time, and it made me happy. He said he had a great morning already, getting up, getting ready, routines that perhaps some of us derive no joy from, because they are routines. These things were giving him joy. The feeling of normal was back. And what a great day. A year ago, I could not talk about this with anyone. Today, I want young mothers of young adults facing addiction to know that there is hope. Look around, we're not alone in this struggle. With the willingness to learn about the illness and the willingness to change it so as to provide the right support, we can help our children, and that the President's new health law, addiction treatment is within reach until our children are 26. Thank you for listening to my story.
Nora's Arabia. What Nora did here today and Ariel did earlier took a lot of courage. Took a lot of courage to stand here at the White House. Did I mention we're at the White House? It took a lot of courage to be here at the White House, you know, as faces and voices for recovery, for themselves, for their families, and also as faces and voices of the Affordable Care Act. I want to thank you all for coming today to the White House. One of the panelists mentioned earlier today that sometimes people show up in treatment and they're rejected. Pam, I think, said it. And they're used to being rejected. And sometimes people in recovery felt that way. They felt like they didn't belong or didn't have a place. And this is the second time that the recovery community has been invited to the White House in the last 6 months. We don't feel rejected. We feel welcome. We feel like we belong here. I hope you found this session as enjoyable and informational as I did. As you leave here today, I want you to remember that you need to spread the word to your family members, to your friends, and to the communities that you live in, for people to get enrolled, especially those who are in recovery. Remember to take the lessons you learned here back to your communities and your organizations. It's critically important, especially to those who are watching on live stream today. Bring these lessons to your community. We have tools that we're going to be getting out on the ONDCP blog and on the SAMHSA blog, so please look for them. We've prepared a toolkit for you to use to get this information back into your communities. Very simple. Not only does it have hashtags on it, right, but it has QR codes. There it is. It has QR codes on it. So all you need to do with your QR reader is snap a little photo of it, and the tool will be populated in your browser, which will be very, very nice. And finally, remember that open enrollment ends on February 15th. That's 25 days away. The open enrollment period this year was 3 months shorter than last year. And it's critical that we get this message out right away. We only have 25 days to do that. So continue to spread the word so that those who qualify can enroll before February 15th. And There is a special enrollment period that requires special conditions to be able to enroll after that, but this will give us momentum moving into next year's enrollment. So it's been a really a big pleasure for me to be able to be here today, to know that 10 million more Americans had coverage last year because of the ACA. We already have over 7 million, 7.1 million people signed up since November 15th, and we need to surpass what we did last year. So please help us get the message out. I'm going to turn this back over to Dave Mineta, who's going to take us home. Thanks, Dave.
Thank you, Tom. And so now let me close our meeting by again thanking each one of you for attending today. For those of you watching on live stream, thank you for joining us here at the White House today. Now, as we open this discussion, I noted the Affordable Care Act represents a significant change in the way services for mental health and substance use disorders are delivered. I say a significant change, the understatement of the day. And as we have seen, this change can and is a very good thing. There's a lot of expertise and energy in this room, and all of you understand the impact of drug use on our nation. You also understand that if we work together, we can meet this challenge and at the same time help those suffering from substance use or mental health disorders. Collectively, we are guided by health, by hope, and the understanding that what recovery brings. We are changing business models right now through important assistance through SAMHSA, through NIATEX, through many of the folks in the room. I am confident, as many of you, that we can continue our efforts to ensure that people requiring behavioral health services get the help they need by enrolling in the Affordable Care Act. Now, as Tom just said, enrollment is the necessary first step, but it is the first step, right? So I'll leave you with a few suggestions on how to remain engaged after today. We've been tweeting throughout the meeting, so if you are not already, I encourage you to follow us on Twitter. Our handle is @ONDCP. If you would like to be on our email list, you can sign up by visiting whitehouse.gov/drug policy reform. Now, most importantly, please continue to encourage individuals in your networks and organizations who need insurance to enroll through the health insurance marketplace at www.healthcare.gov. Again, to underscore, it's both in our talking points. Open enrollment ends in less than a month. And how important for those folks who are either seeking recovery, in early recovery, how important that date matters to not only their lives, the lives of their families, and we would say by extension, the lives of their communities. And I think for our office, we would say, by extension, the life of our nation. So finally, again, it is a special, special privilege and honor that our office was able to host this event today with our wonderful colleagues at SAMHSA, with all of you, to share in the collective spirit that brings all of us back each and every day to what we do, regardless of obstacle, regardless of challenge. It is the collective hope and spirit of Ariel, of Nora and her son, that brings us back each and every day, and will again tomorrow. On behalf of Acting Director Botticelli, Administrator Hyde, I want to thank all of you for your participation today and what you do in the field every single day. Thank you all very much.